right now, on the shelf, we have these drugs. We have diabetics, we have pre-diabetics, we're giving these drugs. Is cardiovascular safety going to be enough going forward? Or are we going to insist that all of our medications for diabetes have a cardiovascular benefit?
Well, unfortunately, you get a situation where the older drugs we're using, basically, no one's going to do those studies. They're very expensive. There's some assumptions in terms of some surrogates that have sometimes not been correct, that they're a benefit. I think, globally, I think that's, the mortality that we see with diabetes is predominantly cardiovascular. So I think given the choice, all things being equal, we would choose an agent that has cardiovascular benefit. It's just not the reality, and frankly, it's not the reality of the economics either. So one has to balance all that and kind of hope to get the benefit in terms of blood pressure, lipids, and glucose control, and hope that some of the older agents are going to have some of those benefits.
Now, is this right now, I know you use the word, Rosemarie, as a paradigm shift. Is that a fair statement? Are we at the point now? Totally. I'll finish the question, then you can say it again.
I'm sorry.
Well, that's fine because you're so excited. This is, it seems to me, I'm an old country doctor, Jim. This is huge. Is it a paradigm shift? Are we really giving something to patients we were never able to give them before?
Yes. Yes.
There you are, simple. We'll go home now. But I mean, this is tremendous. Let me ask you now, with this paradigm shift that we've established, anybody disagree with that, by the way? No. We have the paradigm shift. Should the cardiovascular risk reduction, which I suspect is what you mean by the paradigm shift here, be more of a focus in primary prevention of type 2 in these early patients, keeping them from getting full-blown cardiovascular effects? Or is this now simply for people whose type 2 diabetes has been well established and it's being treated?
I think we all said that we'd like more data. At least there was some evidence from Canvas that in a population that are not secondary prevention, that are primary prevention, there's a benefit. But we don't, the implication was we put it in the water supply, and I don't think we can really get to that point yet, but I think treating earlier makes sense because it's a progressive disease. And so the sooner we intervene in terms of cardiovascular impact, I think would be there. It'd be nice to have the studies. I doubt we're going to have many of those studies.
But I do think that's important. I mean, and I'm plagiarizing this from someone, I forgot who, but I think the focus, just like in other areas of cardiovascular disease, is you don't want to treat disease, you want to maintain health. And certainly, once a patient has had an MI or a stroke, yes, you may lower their risk, but they're still at astronomical risk that you're never going to reduce it far enough. But if you prevent that process from starting, that's where the real magic happens. So if these drugs work in the pre-disease state for cardiovascular disease, that's where you're really going to transform medicine, not waiting till they have an arbitrary diagnosis because they have an abnormal stress test or they have a heart attack in your clinic. In some sense, the cat's already out of the bag. Do we have drugs that work? Yes, that's great. But we're already, the horse has left the barn.
And that's maybe an indication for some population-based interventions as well, because the wave of diabetes and obesity is increasing dramatically, and we need to start looking at what we're doing lifestyle-wise as a population.
And same thing with heart failure, right? If you could prevent heart failure, you know how that would change the trajectory of these patients.
I know I sound like a broken record here, but I'm going to ask this again. What I keep hearing is earlier, 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 before somebody has an event, before somebody has heart failure. How early? Before you can measure their diabetes?
We're seeing type 2 diabetes in children now, as probably the largest epidemic and shift. And so I think the thing is, yes, you want to look at that. You want to look at people at risk and intervene before any of these things start happening. So I think at the earliest is children, looking at both their lifestyle and particularly family risk.
So now we're talking about giving this to very young people who don't necessarily have an established diagnosis. Let me guess you're going to say, but we need the studies.
I don't think we're talking about that yet. I think we're talking about when you're doing prevention, it's got to be primary prevention first and foremost, and then you start thinking of drug therapy when you have to. But now we've got to get people to move and to lose weight.
Well, let me put this on the table, and this was an argument made with the statins early on. If you wait for all the studies, you're condemning, and they work, and the studies show that they're as good as we expect them to be, then you're condemning an entire generation during the study to not have the benefits.
But we're not saying drugs. I think we're all saying lifestyle. And I think so. We don't need a study for that. We have the studies for that, and we're seeing that lifestyle is deteriorating rather than improving.
But you'll forgive me. we have been propounding lifestyle. We have been pounding the table about lifestyle for generations, and you yourself pointed out relatively difficult to do, if not impossible.
But we've been giving people the wrong information too. We were talking about low fat, and the substitute for low fat is high sugar. That may be more of a problem. We have a processed foods. It's like, so really the science that we were using, we now know more than we did.
Stephen, I would love to do one of these with you on our dietary guidelines through the years and where we got it wrong.